It's being recorded.
Absolutely, absolutely.
Okay, good. Okay, so I'm going to welcome everyone to I-CBT Fridays. You guys know our mission is to expand awareness and educate clinicians on inference-based cognitive behavioral therapy. I'm Margaret McCall. I'm one of the facilitators along with Mary Hosbrough and Sylvie Levine. And our job is to plan and facilitate content for I-CBT Fridays. Now this summer, this is our last actual plan presentation until the fall. And so we're probably, well, not probably, we are going to go back to open discussion, case consultation. Most of those won't be recorded. And I think it's a great opportunity for you to get free case consultation with some of the experts in the group. So come on Fridays and bring your cases and we can have an open discussion and all learn from each other. Today, this presentation is being recorded and we have a special guest. It's Adil Tarar. I said it wrong. Adil Tarar. And Adil is from Lahore, Pakistan. He is a layperson and also a consumer with OCD. And he's going to talk to us about his journey in learning about all of the different approaches to OCD. And he has a really very good understanding of the different approaches, has researched them, and how he came to land on inference-based CBT and how that has worked for him. So without further ado, I'm excited to introduce Adil. You go ahead.
Thank you very much, Margaret, and thanks for the introduction and the kind words as well. The thing is, to start with, I would like to discuss about the brief history of my OCD episodes and how did it all started. Actually, it started in 2004, 20 years back, but it didn't mean that I remain in the deep clutches of OCD most of the time. I had my good times, but then occasionally I have relapses, maybe once or twice a year. And as anyone else, when we have good times, we do not think about the bad times most of the time. And when we have the bad time, we always want the good time back so we can catch it somehow. So in 2007, first I went to a psychiatrist and he get me started the antidepressants without diagnosing that I have OCD. Then in 2011, I've been diagnosed with OCD. And I was just keep taking the medicines. Unfortunately, at that time, and even now in Pakistan, we do not have access to good OCD therapists. And but the thing is that I always have subclinical symptoms as a patient. I was never deep into OCD, but the problem was, then again, every now and then, maybe after a year, after 6 months, I again have a relapse, again have an episode. So then in late 2020, I decided that now I need to go deep into the understanding of OCD if I really want to get rid of it once and for all. And then I go through the literature and I start reading the books, the YouTube channel, the podcast, and the article as well. And lately, I also read some research article as well on OCD. Then after 1 year, I went to a therapy with OCD Center of Los Angeles, and I took only 7 to 8 sessions because it was most like a collaborative sessions. And at that time, actually, I almost know everything about OCD. And actually, the therapist himself said me, do you really want anything to learn from me, or and you just need to apply it? Cut the long story short, the problem was, okay, I will discuss about the technique that I read. I read about the classical version of ERP, then the modified form of ERP, where they add the metacognitive approaches and more work on the cognition, like the work of Sally Winston and Reed Wilson. Then I read about mindfulness-based interventions, ACT, and many other interventions. And most of them have different rationales, but their base is almost the same, that it's about the management of the symptom and it's about the tolerance of the symptom. The problem is, after reading all of them, if I imagine my OCD as a circle, and the mid of the circle is the most severe form of OCD, and I was always at the edge. I was always at the edge. I learned a lot from these techniques, but and I always use the gentle version of all of these techniques. I never use scripting. I never use unnatural exposure. I never use all other unnatural kind of interventions. But the thing is, I never get that freedom which I was pursuing for. I mean, I never get out of OCD completely ever. And there was always a burden, which is most of the people have who are doing ERP, is that it seems like that we are not doing enough. We need to do something extra. Actually, at the time when you're enjoying the moment as well, it seems like maybe I need to generate some uncertainty or discomfort and then to tolerate it. And then I also felt the sense of confinement which come with the fear of compulsion, that maybe I'm doing this. Is this a compulsion? Is this not a compulsion? So as I said, I was doing good. I was doing fine after reading ERP, after applying its rationale in my own language. I did not apply a formal therapy or anything. So I was enjoying my life. Life was happening, but there was a last step which was always missing. I mean, I never got to a point where I want to be as free as anyone else, or as good as I was before actually having OCD. So then one day I was just scrolling down my Twitter feed, and I read a tweet by Mike Heddy, where he mentioned that I'm learning non-exposure based technique for OCD, which is I-CBT. If anyone has any question, he can ask. And when he first read it, I said, okay, fine, it's the same old story with different words. But anyways, I will ask him. And I was the first and the only one who actually asked any question, that is there any manual which you can read, and what is different I-CBT in regard to the other techniques. So then he mentioned the book, Clinician Handbook for I-CBT. I straight away bought that book, downloaded it, and I started reading it. And from here on, we will get to our first slide, with is now the discussion points. The first discussion point was about OCD obsessions. Up until now, I was having a view that OCD obsessions are normal obsessions, and our response to these obsessions are the real problem. And actually, I was applying it. I was tolerating the discomfort of obsessions, and I was letting them come and letting them go, and living my life with my values. And it was somewhat working fine for me. But
Adil, can I pause for a minute? Did you say you are sharing your slides? Because we're not seeing slides. So if you are trying to share slides, I want to help with that.
Actually, I have shared my slide with Margaret, if she can.
Oh, okay. So
yeah.
let's pause and get that.
Yeah, that's fine.
It's going to take me a minute, Mary. Let him
Okay.
go ahead and I'll get it going. Okay.
Okay. Sorry about that, Adil.
No, that's fine. That's fine.
But you can continue discussing if you would like until it's up to you.
Yeah. Before I-CBT, one thing I was confused about what I read in ERP. I had my apprehensions and about scripting, about intolerance of uncertainty, about the language being used for reassurance. And I have my own commonsensical view on that. And I was applying that. But the problem was I need a backing of a research-based expert opinion. So when I read that, I got that expert opinion, which actually vindicated the concept I already have. And then I learned a new perspective on OCD. And yeah. So can we go down to the next page, which is, actually, I'm unable to click it. Margaret, can you do it?
Yeah, how do I click it? Which way do I go? I've never used this. I don't think. Oh,
On the
here.
left, on the left side.
Gotcha. Thank you.
Okay. Now, that's fine. The discussion points are OCD obsession. So should I need to start from the very start?
No,
Well,
continue where you are, Adil.
Yeah, actually, before I-CBT, my view of the obsession was that these are normal intrusion, normal obsessions, and our response to these obsession are the real problem. And actually, frankly speaking, it was quite working fine for me in a way that I start becoming more comfortable with my obsession, and I start watching them as just passing events and living my life by my values. But the problem is it was fine most of the time, but at some time, few obsession or thoughts have a very serious sort of pull. And when I trace back to that obsession, I used to use that language that it doesn't seems like a random thought. Actually, it seems like that is taking its content from somewhere and it twisting it and then it presenting it to me. That was my view even before I-CBT. But I never had a language to speak it. But when I read the inference terminology in I-CBT book, I was absolutely shocked. I was shocked because I always have an opinion about it, which is quite reminiscent to it, that it never been a thought, a simple random thought. As we as a human would never become comfortable, it does not matter that how horrible the thought would be until unless it does not have an imaginative story attached to it or any imaginative association with it. So that gave me a very different perspective on obsession. And that gives the answer of my same old question, why OCD feels so real. And first I was told OCD feel real because there is an emotional charge with your thought and you feel that charge, and this is the reason it feels so real, and it's a feeling of uncertainty. But the reality is, even if it is an emotional charge, there must be a reason for that emotional charge. And now I got the answer, what is the reason for that charge, for that pull? And the reason is because there is a story attached with it. It's not a random thought, it's a complete story, it's a conclusion. So that's how I get into I-CBT. And I was the one, actually, I heard many people saying that it took quite a time for them to understand I-CBT properly. But the thing is, I have a vision in my mind even before coming into I-CBT. And when I read Inference, I was absolutely shocked about it, that how true it is. So from here, my perspective gets changed about OCD. And like, so if you think it's inference, not obsession, the whole intervention got changed. So now can we go to the second point? Hello?
I'm sorry, Adil. I'm not going to try that again to put it in presenter view. Let's see.
Actually, I have that slides on my mobile, but
Yeah,
I think
you want to do it on your end? Here. Oh, here we go.
But now you're not sharing again, Margaret.
I know. I got to
Okay.
share. I wasn't prepared. I wasn't thinking. Oh, there we go. All I have to do is click it. Okay, good.
no, actually, this is the third slide or the fourth one. I need the
Three.
second one.
Okay, there we go.
No.
Oh, it just lets. That's
No, this one.
okay.
Now,
Sorry,
the second thing is, now we need to understand what is the core of OCD. And now I'm comparing different techniques, what I thought before that and what I thought after I-CBT. The first one is intolerance of uncertainty, and I would take some time in explaining intolerance of uncertainty because this is something which gives me the more discomfort. And I have some problem with this actually phenomena. The second one is faulty appraisal versus inferential confusion. So can we have a chat on this? Can I take 5-10 minutes explaining this?
Of course,
Yeah.
go ahead.
So the thing is, if we say that core of OCD is intolerance of uncertainty, then my first question would be, is there any proper research on it, a deep research, where are research articles that can confirm that core of OCD is uncertainty? And the great news is, no, we do not have. So the next question is, and all of these questions I have actually even before reading I-CBT, but that was very random ideas. I mean, I never give them articulated shape. So the second thing is, if it is about intolerance of uncertainty, then why it's so specific? Human traits have never been so specific that sometime if I have some theme of OCD, I am intolerant to that possibility, and at the same time, I am not intolerant to all the other possibilities in the world. Actually, I am better in handling the other uncertainties. So how it's so specific? And even in the same theme, on multiple things, you are not concerned about, and you're just stuck on very few things. If it is intolerance of uncertainty, if this is a trait that you have, then it should present itself on the other part of your life. So that was quite actually confusing for me. And on another level, for example, if someone is have an OCD symptom of being pedophile, that I can molest a child, then it happened to every OCD patient every now and then, that somehow their theme change suddenly. And then the very next day, if someone discusses about you about the pedophile theme, you simply can dismiss it very easily. If it was intolerance of uncertainty, how with the change of theme, the whole intolerance has gone away, if it is a proper matter of intolerance of uncertainty. So what I personally believe is OCD is not intolerance of uncertainty. And I have other point to discuss as well. In my opinion, this is a flawed and a made-up phenomena. There is a difference between intolerance of uncertainty, intolerance of different possibility versus overinvestment in different possibilities. When you invest yourself in the imagination out of the reality, then you make multiple attachment over there. Then you make stories over there, and then you stuck there. This is the problem of OCD. It's not about the intolerance of OCD about anything. And secondly, I have a problem with the word intolerance of uncertainty as well. It's nothing more than an expression. And at the very best, you can say that intolerance of uncertainty is a symptom of something. Even if there is intolerance of uncertainty, there must be a reason of you being intolerant to something. Then that reason is the core of the problem, not uncertainty itself. So these are my actually reservation about uncertainty model. Anything anyone want to say about it?
I just appreciate you talking about uncertainty in this way, because I do find that now that I've learned about I-CBT, I have a really big problem with uncertainty and how it's used.
Yeah, actually, there is another thing that if someone has a lived experience of OCD, I encourage him just sit down and think about it with two different perspectives. With the perspective of inferential confusion, either you're over investing in some possibilities, or they're simply intolerant to something. And I'm quite confident that they will come up with something that is being stuck and over investment in the possibilities rather being intolerant to possibilities. Actually, we human are not intolerant to possibilities. That has never been a problem. There's never been a problem. The problem is where we invest our consciousness. If until unless we do not make imaginal association with the possibilities, we will never be intolerant to them. There are zillion possibilities in the world. We never think about them. They're totally irrelevant. until unless they have an evidence. If there is evidence, then of course we will handle them. So this is how I think about it. The second rationale in ARP is faulty appraisals, which says that the obsessions are normal. We appraise them wrongly, we give them wrong meaning, and then we generate anxiety out of it. Well, if you ask me, it's still better than intolerance of uncertainty, much better for that matter. But the problem, as I said, that if we can all agree that it's inference is not obsession, which I am absolutely convinced of, then this discussion is gone actually. The whole matter has already been done before you're having a thought or obsession. So the next thing is inferential confusion. As you everyone know, I have my own language of explaining inferential confusion. So I would say inferential confusion is when you invest your attention into the imaginative world, you leave the reality, you go there, and then you start making stories over there. And imagination have a very different sort of word. It has a power to absorb yourself into it. And then you start making different story and narrative out of it. And out of that narrative, you would definitely make multiple conclusions. And that conclusion at time fight with your reality. And that's we call inferential confusion. By definition, it makes absolute sense. But if someone has OCD, he sit back and he observe his own experience and obsession again and again. And after every try after try, he will come up with the same answer, that is inferential confusion. I was more than 100% convinced that the whole OCD problem is the patient is inferentially confused. It's not about intolerance of uncertainty, overestimation of threat. These are all nothing more than symptoms. And whenever you have a symptom, there is a reason of that symptom. And all of those cognitive traits, intolerance or overestimation or over-responsibility, these are not material things. Thinking and inferential confusion is a material thing that you genuinely doing in your mind. And this is the real problem. You solve that and And when you solve inferential confusion, what happens? You generate clarity in your mind. And when you generate clarity in your mind, trust, confidence, sense of certainty, these are all effortless byproduct of clarity. If your mind is not inferentially confused, you need to do nothing to trust yourself. You need to do nothing to be confident. You need to do nothing to feel sense of certainty. This is how we are wired. Just generate clarity in your mind and just get rid of these competing voices. Not get rid of them, just realize what they really are, and you will feel all the feeling that you want to feel: trust, confidence, and sense of certainty. So that's it for this point. Anything? Can we go further?
Yes, you want me to share the screen again?
Yeah, of course. So the next thing is doubting, emotional doubting versus verbal doubting. There is a book on OCD, which is known to be one of the best book in ERP world. And the whole ERP rationale and all the different techniques say that OCD doubting is an emotional disorder, where you have simple doubting. For example, if you wash your hand, I-CBT and ERP both agree that OCD patients do not have perception problem. They know as much as anyone without OCD. ERP says, if you wash your hand, and logically, you know they're clean, but you're not getting that emotional feeling that they're clean. And that emotion is the problem with OCD. So you need to tolerate that emotion, and with time, that emotion will wear off, and you will get back to your normal living, which makes sense actually. But the question is where that emotion is coming from. I mean, no emotion come from nowhere. And that I learned in I-CBT, that the doubting in OCD is not emotional, it's verbal doubting. When you doubt something, there is a reason behind it. It's not just an emotion. There is a story behind it. There is a justifiable story, OCD justifiable story, which is, though it's distorted, it's wrong, but it's justifiable with distorted reasoning. And when you unravel that reasoning, when you identify that reasoning, you can identify the imaginary and irrelevant nature of OCD, and then you can trust yourself, and all the emotion will follow. And you can feel the emotion which you like to feel, like you can feel that your hands are clean if there is no competing voice in your mind. So anything about that?
Very clear, Adil. Continue.
So the Margaret, can you go to the next slide, please? This is one of the favorite thing I would like to discuss. Take on reassurance in ERP and other techniques, and in I-CBT. In I-CBT, we believe that all the sequence start from an obsessional doubt. If we handle that obsessional doubt, everything settled down by itself, which is right. If you read ERP literature and the other modalities literature, you will find quite open-ended, confused, and a fearful language in a way. Even the experts are describing reassurance with lot of limitation, with the fear of reassurance becoming a compulsion. The thing is, reassurance, reality-based reassurance, is a part of normal human living. It's not only fine, but it's actually necessary. In the face of doubt, you access to the reality and you reassure yourself what is reality, and then you go on with that. In ERP literature, it's quite unfortunate that we have gone too much in the behavioral aspect of the things, that we have made the word reassurance a compulsion, a theoretical concept. That if you will use this, for example, I read this in a book, one of the best book in OCD world, that if you have a doubt, my hands are dirty, do not say they're clean. Say, I don't know if they are dirty or not dirty, but I can only say that I'm not feeling good about it and move on. Well, I have a very serious problem with this. Are normal people behave like this? Do we say the same to the normal people? At the name of reassurance, aren't we saying people to do something which normal people are not doing? So all I want to do is, actually, why I'm explaining it too much, the thing is that I'm also a victim of this, that I struggled so much for so much long time. Then I was fine with my life, but I was stuck in a paradox of, is this a compulsion? Is this not a compulsion? Is this a compulsion? Is this not a compulsion? Even the simplest of the thing. And for a normal person, this discussion does not seem like a big thing. They take everything with general conception, but for OCD patient, it can become paralyzed. And actually, when I get my therapy from OCDLA, I ask my therapist about different questions, and then I asking about the question I am asking to you, are they compulsion? And then, I mean, a person get paralyzed. So this part of ERP and the rigidity, the fear of reassurance becoming a compulsion is something we need to be wary of. We as a human use a reality-based reassurance all the time. We need it. The only thing is we need to be wary of that reassurance doesn't become compulsive, and it will never become compulsive if you address the real thing, the imaginative story in your mind. If you break the story, you will be in the reality. Then you will use what you want to do. And this is exactly what I read in I-CBT. Since actually, if alternative story in itself, it's a reality-based reassurance. And it always helped me. So the concept is compulsion need to be explained. Even if you're doing ERP, I think the rigidity around reassurance and compulsion is really devastating, and you always feel a sense of confinement and fear all the time. So this is something actually I-CBT make me free of, and now I am in a freedom. I can say anything, I can speak anything, and by content, nothing is compulsion by content. It's a functional concept, and the functional concept mean we need to see how does it function. So this is something I really give credit to I-CBT to make me free of these limits and this burden of doing compulsion. Am I doing compulsion? Am I not doing compulsion? And this is my advice to the people as well, OCD people. If you're doing cognitive work and I-CBT, never being afraid of using a proper access to the reality through your senses. And so that's about the reassurance. Anything anyone would like to add? Margaret, can you go to the next slide?
You see it, Adil?
Yeah, I can see it. Yeah, that's fine. Another problem is scripting and self-induced discomfort and uncertainty techniques. The number one is imaginal script. I never applied imaginal script, even I applied the techniques of ERP. And the reason being, it never made sense to me. Why? Because it's not natural to normal human living. Have you seen anyone in real life saying that I drove the car from there and maybe I hit someone, maybe he's died, but I need to tolerate it, and no, I can be caught up by police, but that's fine. I need to work around it and move on. The unnatural nature of scripting is was quite put off for me. The second thing is maybe not statements or uncertainty statement for that matter. I will say the same thing that I said before, that for a normal person who does not have OCD, if we use such a statement, for them, this is a journal statement, maybe not, they will say it, they will move on and all. But it has its deep consequences in a way. When OCD patient used to use such statement, uncertainty statement, it provoke anxiety at first. And second, it provoked confusions. They got confused. Am I saying, for example, if someone with OCD would say, maybe I hit someone, maybe I did not hit someone, I can handle uncertainty. What does that mean actually? Is it 50-50? But if you will ask to OCD therapists, they would say, no, it did not mean 50-50. It's mean that possibility exists. But that's the exact problem. That OCD patients do not think like it. They go deep into it. They make multiple attachment with it, and then they make stories out of it. And all of these uncertainty statements are the best thing for OCD to use and make a imaginative scenario out of that, and then that obsessional doubt. So if you think you can use the language of possibility better than OCD, then you're absolutely wrong. OCD is always better than using the language of possibility. And on another level, have you seen any person using such statement in real life? Whenever we have a problem, whenever we have a doubt, what we do? We simply connect with our senses, what we genuinely think, and then we move on with that. We never say maybe, maybe not, if it happened, this, that. So again, as I said, it's quite unnatural to normal human behavior. The third thing is unnatural exposures. I read in a book, a very prominent book in OCD world, for someone with hit and run OCD, first, the exposure could be that you can have imaginary exposure and other thing, but a physical or in vivo exposure would be that you drive your car on the road and blink your eyes for every 5 seconds. And this is one of the most prestigious book. I can never buy this idea. And I exactly know what they mean and what they want to achieve, what discomfort they want us to achieve. I know it, but it's completely useless. Even if you want to do ERP, that's fine. Even then, all the unnatural exposure are extremely unhealthy to do, first. And secondly, the same thing. You will ask them to do this one exposure, but they will generate stories about it. They will start thinking about the other part of their life. Maybe with that language, there could be such kind of a exposure in this moment. So again, they will caught up into that imaginative world. Now, if we see into I-CBT is completely against it, we ask the people to don't cross the bridge. We want them to avoid the OCD bubble, not going deep. We want them to live in the reality with your senses and not going into the world of imaginations. So that's pretty much it. Anyone, any question about this point? Can you go further?
I would just wanted to say, first of all, you're in good company here because a lot of us have OCD, or some of us anyway, self-included. And scripting for me became compulsive. And that was one of the reasons I had to stop doing ERP. It just wasn't useful anymore. So I'm just, wanting to add to your story there a little bit, but also maybe not for one of my clients, really added to, it's like, so she had her feared thing. And when she did ERP, they used those terms or, that tool. And so for her, that just solidified that, oh yeah, well, this thing is real, but I just have to keep going on with my life. So it actually strengthened her obsessional story. So.
Well, actually, I would like to go to a point where first is unnecessary torture. And secondly, if you ask me, at some level, it seemed like a bit unethical as well. A person is in a deep trouble and you are giving him some sentences which are actually magnifying the problem. And as I said, that for a normal person, maybe not is just maybe not. For an OCD person, he will attach 10 different things with it. That's the real problem. Then he will start generating other doubts out of that, maybe not. Then he will start obsessing about that doubts. And same as we see in I-CBT, we generate stories out of that uncertainty language. So yeah.
Can I ask a
Go ahead, Susan.
Yeah, I just wanted to make a point that I've seen both responses among clients who've had ERP, clients who I've done ERP with, and clients who insist they want ERP now. Some will get more confused by maybe not, by these kinds of exercises. Some make it more confused, but I've seen others who don't. And I think what's going on is that they're not believing the maybe not. They're not believing anything is possible. They're just tossing it off. And, they say they're buying into it, but I don't think they are. So, I mean, that's my interpretation as why they're doing okay with it. And I haven't probed too much because they're doing well. So I decided to leave that alone. One fellow I work with who went through McLean's, residential program, did very, very well there. And he absolutely wanted to continue with the behavioral program and ERP, and he's doing very well. But he continues to do daily ERPs, and he makes them up, and some of them are hilarious. And some of them have helped him with conflict avoidance and things like that. So it seems to be working for him. It looks to me like he's anxious, and he says like he's generally anxious. He says he's not. And so he is doing things in his life overall that he hadn't been able to do before. So I see progress in him. And I think my assumption is that he's overall anxious. He says he's not, and he seems to be functioning very nicely. I think he's just saying, oh, anything's possible. And I don't think he believes it.
Susan, we're going to thank you so much for those comments. I'm
Well-
noticing the time, and it's 1:43. Adil, I'm not sure how far I know, right? So you might want to zip through and not ask for comments too much if you want to get to your
I
rest.
would actually. I have a few other points, but I will make them quick now. Yeah.
Okay.
So let me check what I can skip for that matter. Actually. So okay. I think we can skip the last point and we can go on to the next slide.
Okay, Adil, and we can have a part two. We've got the whole summer. So if there's something you missed, you want to come back and talk some more, we'd love to have you back. Okay.
Actually, not at this one. Actually, the slide before this. Can we go back? Yeah, over here. Okay. This one. Yeah. Actually, this is the most fascinating point for me to discuss in the prospect of I-CBT and OCD in general. Trusting, which is a product of reality versus obsessional doubting, a product of imagination. We need to understand that trusting our senses, trusting ourselves is the natural, effortless, and automatic process that we are wired with. We all say that we want to trust ourselves, but the reality is we are wired to trust ourselves. We are bound to trust ourselves. This is how we are physiologically and neurologically built, that we trust ourselves all the time. And if we compare it with obsessional doubting is not automatic. It's not natural. It's not, it's effortful. And we cannot obsessionally doubt anything unless we attach an imaginative story with it. For example, we are having a chat. I am Adil, living on planet Earth, and we're having a discussion. If I ask you to doubt that I am an alien, can you doubt it? With all of your efforts? Probably, generally, I'm not talking about the exception, but probably every one of you would not be able to doubt it. And the reason being is obsessional doubting is not normal. It's not natural unless there isn't any evidence. We are not built to doubt ourselves. And now I ask you, are you trusting that I am having a discussion? I am Adil, I am on planet Earth, and you are trusting this without making any effort of trusting. So this is a great point to understand in OCD and I-CBT, that for trusting, we do not need to do anything, absolutely anything. We just need to solve that imaginative word that we have made. And when we are out of it, we are back into reality, we will start trusting ourselves effortlessly. The great thing about trusting is it's completely effortless without any intervention. Obsessional doubting is always effortful, and we have to make a lot of imaginative work to obsessionally doubt something. So and again, as I said, if you want to trust, and at a place where you're not trusting yourself, then there is a reason you're not trusting yourself, and that reason lies in the imagination. You solve that reason, and then automatically you will get back to normal human living, and you will start trusting yourself. So the next point is the next 2 points I will explain. Humanistic approach. I-CBT seems like a humanistic approach. It is absolutely in line with how we live our life, how we use common sense as normally, rather than saying something which is other people are not doing. And then at the end, I would say that I-CBT give me the freedom to say whatever I want to say, whatever way I want to say. On the contrary, ERP put a lot of burden on me and a lot of limitation. And actually, in ERP, I strongly believe that we can also do ERP with a way more gentler, with a way more humanistic approaches. So I think we need to change our language in ERP at some level and make it more in line with normal human behavior. And but as I said, that what is the point of tolerating something if we believe that something is a nonsense? And tolerating nonsense, in my opinion, in itself is a nonsense. So as a human, we disregard the nonsense rather than tolerating it. So yeah, that's pretty much about the presentation. Now, anything if you would like to discuss about.
Hey guys, the floor is open. I just want to say, is Mike Hetty here in the room? I can look, because I didn't know until today that you had actually found about I-CBT through Mike on Twitter. And it was really interesting that then you connected with Carl, who connected you with Fred, who connected you with me. And then we've had some conversations. So your journey to I-CBT, to this community, is really cool. And what you guys may not know is we're talking to Adil and some other people about doing client advocacy. I know a lot of you have asked about support groups and Facebook groups and things like that we can use. And I, for one, vote for Adil to help us work on that. I think he's on board with that. So you guys ask questions. You have 10 minutes. Or comments.
I'll just have a comment. I mean, great presentation, Adil. I especially like what you get across very well. You know, that trusting does not take any effort. Because trusting is something that we automatically do, and we only can sort of stay in the way of, you know, or create doubt through the imagination on top of it, and then the distrust starts to come in. But it's actually natural to trust, and it also ties in with reality sensing in CBT, right? Which is also not putting in additional effort, and it's not to tolerate anxiety. It's not. You can call it a behavioral exercise, but not really. It's just doing things without effort normally. You know, you're not testing anything out with reality sensing, because if you trust yourself, it happens automatically. So that's what we want to bring a person with OCD back to, you know. So I thought it was a very good point. You know?
Yeah, actually, and in my opinion, this is actually the crux of OCD and I-CBT as well, that we need to understand the mechanism of trusting. Trusting is something which happens automatically. While having this presentation, we are trusting multiple things. I am sitting on these chairs. I hope that the roof wouldn't fall on me. I am talking to Fred. So, I mean, we are trusting, and without any effort at all, because we are physiologically wired this way. So, but for obsessional doubting, it's an effortful process, though we do not want to do it, but somehow we get into that.
Adil, could you talk a little bit more about how that process was for you personally? Like how long it took for you to begin to really learn that? I know you touched on it for sure.
About I-CBT.
About adopting what we were just talking about, learning to recognize.
Sorry, I couldn't.
Learning to recognize when you're doubting versus shifting over toward, I'm sitting here right now talking with this group. I'm thinking of resistant clients or acute cases that I have, and I'm still struggling with these clients, and I do not have OCD.
Well, as far as with the viewpoint of I-CBT, I think we need to understand the very first thing about I-CBT is it's not a technique. It's not a set of tools that you need to do. It's a therapy of realization of the imaginary and irrelevant nature of OCD. And when you will go there, actually, most of the time, some therapists work on that. I will tell you to do this and you will do this and you will get better. Actually, this is not how I-CBT, in my opinion, work. It's the therapy of realization. You need them to realize that actually what's happening, what they're doing different than the normal people. And when they will understand that, then definitely it will be very easy for them to get back to reality and reality sensing and all, if it makes sense.
Thank you.
Thank you.
That makes total sense, Adil, that it really is. If it works in the first 4 sessions and you begin to realize what you did to get you kind of caught up in your obsessional doubts, you don't have to worry about resisting doing things. You just naturally stay in the here and now, right?
Yeah, exactly.
Yeah.
I mean, normal living is so automatic. For example, we can do experiment on it with your partner, anyone at your home who is not OCD. If you observe their life, they wake up, they take a bath, they get ready, they eat their breakfast, they go, and they do all of this without any effort, without zero effort. And they never become obsessive about anything. I mean, we need to understand the automatic, natural nature of living in reality. So, so as I said, that I-CBT for me is a therapy of realization. You understand what's happening and what you're doing, which is different than the normal person. And when you recognize that all is, because functionally, when you're applying I-CBT or any other technique, you're not thinking about inferential confusion, inference, and this and that. In the moment, you always know what is what, and then you need to move on with that.
I like how you pointed out pretty much like a commonsensical approach to understanding OCD. It's like, you know, it's like when we live with OCD, we kind of know this on some level, and then I-CBT gave us that framework. It really kind of confirmed our common sense about it anyway.
Yeah, exactly. Absolutely. Because as I said, that I-CBT does not teach you anything new. And anything new mean, of course, you learn thing how your brain is working. It tell you actually what's happening. And when you understand what's happening, then you exactly know what you need to do. What the main point is, there is something different between you and the person who doesn't have OCD, or even on the other part of your life, which is not affected by OCD. You're doing something different. And that difference is everything that you need to learn, and how you can attach that 5% of your part, which is affected by OCD, to the other 95% of.
Yeah, to tag onto that, I-CBT is right. It's about not learning anything new. You're absolutely right. It's about taking something away, which is unnecessary, unnatural doubt.
Exactly.
Confusion created by this unnecessary layer of the imagination, which a person with OCD transposes upon reality. So I-CBT is taking all these cognitions away. I've said it before, but in a way, I-CBT it's a very cognitive treatment, but there's also an anti-cognitive component to it, because we want to take it away, all this stuff, so that people do it naturally. In that sense, philosophically, you can almost say that I-CBT is more behavioral than cognitive. You take away the effort.
Yeah, exactly.
Right? So talk about ERP and all that. I-CBT is not that easily pushed into a corner of it being behavioral, cognitive, or anything like that, because we want to bring people just back to who they naturally are.
Exactly, yeah.
something away, not adding to it, or learning something new, or learning how to tolerate something that does not need to be tolerated.
One thing I would like to add is that when we talk about imagination does not mean just imagination possibility, or you have your reality, you want to do something, you want it the way you want to do it, you have your logic, you have your values, and anything which is beyond reality, which would get you beyond reality in the imagination, any imaginative scenario, it could be possibility, it could be blending, it could be mismatching, anything would get you away from your own reality. That would be, I would say, the word of imagination for OCD, and for you to realize it when it's happening, and then you're getting back to the reality, and that's the whole treatment. It takes some time, but actually it's so natural. The great thing about I-CBT, again, I would say, you do not need to learn anything. You need to realize what's happening and what needs to be done.
Adil, in your online life, have you met other people with OCD and explain this to them, explain your journey, explain your experience, and if so, do people understand it, or are they attracted to it, intrigued by it, or does it sound like?
Well, actually, as I said before, that unfortunately in Pakistan, there is a stigma around any mental health issues. So most of the time, if someone has OCD, we do not have an open access to the person. And I discussed my story at one or two places on the forums. Otherwise, no, I didn't do it as of now.
And when you discussed it on the forums, what was the response?
Actually, it wasn't the complete story. I just used to give the responses and in the form of reviews, and mostly I didn't get much of a response. Yeah.
A long time ago, I saw your post already. It's various places, which was a response to YouTube videos and Twitter and all that. And already back then, I thought, like, who is this guy that seems to understand I-CBT so extremely well? And I think it's quite amazing how you make sense of it from a personal level, and how deep your understanding of I-CBT goes, which can take a long time for some people to understand, which is normal. It's okay, but the fact that it resonated with you is also something we hear often from therapists who have OCD. It clicks with them right away. When you have OCD, it clicks very quickly. So having OCD actually helps with understanding I-CBT in a strange way. So, well, I thank you for being here, and I hope that your story also will be helpful to many who listen to it. And I hope you tell your story again and again.
Thank you. I'm going to let you get some last closing remarks. It's 2:00, and so we're going to wrap up. But is there anything else you want to add today? I really appreciate you talking to the group. I think everybody enjoyed it. I know I always listen. It's probably the 4th time now I've heard you talk about your insight into I-CBT, and I never tire of it. And I'm sure when it goes on video and goes on the I-CBT website, it'll be very popular. But if you have some way you want to close, and then we'll tell everyone goodbye.
Actually, thank you very much for everyone, and thanks for having me. And again, as far as the advocacy is concerned, I think I will be in connection with you and Carl and maybe Fred, so we can discuss that over there.
Perfect. Thank you. You guys have a great weekend. Have a good weekend, Adil.
Thank you.
Thank you.
Bye-bye.